stent between point A, which is the proximal reference, point B, which is the distal reference, angiographically. So people can confirm that by doing IVS studies, they found that almost in 40% of the time, point A and point B are disease zone. So one third of the time we are making big step. One third is a big number. So that's not a small number. So angiographically normal vessel doesn't mean IVS face normal vessel. So what is the implication? If you land the stent, especially a DES in a disease zone, it is known to have a higher MACE events. So once the plaque burden goes more than 40%, what is plaque burden? First point, I will show some IVS picture and we'll go through it. Let's presume this is a normal lumen. Okay, I will show IVS pictures later. So this is a normal lumen. This is the lumen. This is the intima. This is the media. This is the adventitia, external elastic membrane. Okay, I'm sorry, external elastic membrane. This is the yellow color is the media. So if you calculate if you calculate this surface, I mean CSA, cross sectional area of this big circle as compared to the small circle, there should not be any significant difference. The volume of yellow volume is the media volume. We all know that the plaque is going to deposit inside the media in a chronic stable lesion like this. So once this yellow color increases, that become plaque. So what is the plaque burden? Plaque burden is the surface area of this big circle minus surface area of the small circle, that's the lumen area, divided by surface area of the big circle. That means how much amount of volume of this bigger circle is encroached by the plaque. That is plaque burden. When we say plaque burden, it's not a big terminology. It's the amount of plaque that is inside the particular segment of the vessel, amount of plaque that is inside the particular segment of the vessel, the occupying the particular cross sectional area of a external elastic membrane. That is plaque burden. So in order to define remodeling, let's go into the next slide. Okay. So I will discuss about remodeling in the forthcoming slides. Before going into the remodeling, how to do IVS imaging. It's very important to follow some basic steps while doing IVS imaging. The guide should be coaxial. First point, it's radial or femoral, doesn't matter. Guide should be coaxial. Workhorse wire is the key. Motorized pullback is very essential. We should go 20 millimeter distal to the lesion, and pullback will be done up to the aorto-osteal junction. Vascular dilatation is essential. I will show the slides why it is important. So by doing all these steps, we are trying to acquire an appropriate IVS image. Acquiring an IVS image is not the isolated step that we are doing it. We have to analyze this image properly. If you don't have basically in all the Western countries, there is an IVS image coordinator who interpret the IVS image while you are doing the procedure. If such system doesn't exist in any hospital, then we may have to deglove, go and see the image, analyze it, and then act accordingly. So this is the three A's of IVS: acquire, analyze, act, so that appropriate decisions can be made for better outcomes. So this is the image published in European Heart Journal 2018. Stent size can be decided based on distal reference segment, minimal lumen area segment, or proximal reference area segment. If you look at here, IVS and OCT, the more small, we can start from the smallest reference area of EEL all the way to the smallest reference lumen area. If you anywhere you mention the dimension, there are two dimensions. One is the minimum dimension, other is the maximum dimension. The third dimension is the mean dimension, summation of the two, average of these two. That is the mean dimension. So you can take stent based on this dimension. You can take stent based on this dimension. This is lumen based minimum or maximum or average of these two. That is mean dimension. So if you don't have a good reference segment, then you go with the minimal lumen area. If you see this in OCT, you cannot use this criteria, but in IVS you can use this criteria. This is called as mid wall to mid wall criteria. So you don't see any good landing zone. You are not seeing any region in the vessel where the plaque burden is less than 50%. That time you will go at the minimal lumen area side, go to the mid wall of the plaque to opposite segment mid wall and take a stent and deploy it with an appropriate strategy. And similar to the distal reference area, you can use the proximal reference area also. And people have also utilized the mean of proximal and mean of distal, summation of mean of proximal and distal divided by 2. That is average of mean of proximal and distal reference area have also been used. So these all the values vary significantly. The if you want to be less aggressive doesn't mean you are scary. Less aggressive means you are ready to post work more rather than creating a bigger complication because of selecting this bigger lumen from the beginning itself. So less aggressive means you are going with the minimum dimension of the distal reference area segment, and more aggressive means you are going with the maximal diameter of the external elastic membrane. I hope you guys are following me. This concept needs to be understood very clearly before dealing with stent sizing by IVUS imaging. So if you go from here to here, the aggressiveness grossly decreases. I'm not discussing anything about IVUS because this topic, I presume, for postgraduates, you guys know about the basics of IVUS. So how to identify can you see a tunica intima in IVUS? You cannot see tunica intima in IVUS. You presume that is a tunica intima. We only see external elastic membrane in IVUS. We only see external elastic membrane, media, and internal elastic membrane. Any structure seen inside the internal elastic membrane is the tunic adventitia. So we cannot see tunica intima. We cannot see tunica intima in IVUS. We can see tunica intima only in OCT. So before going, the talk is predominantly based on IVUS because I personally feel IVUS is excellent modality as compared to OCT, especially when dealing with larger vessels, where imaging has been convincingly proven to decrease MACE events. So before going with the stent selection strategy, let's discuss about some of the artifacts that can happen. Wiring is an important key. If the vessel is going to be have significant tortuosity, accordion effect is going to happen. In that particular situation, you may have to change your wiring strategy because this creates a lot of pseudo lesion. Just like an angiography, the IVUS image also looks. This is the normal segment here. Once it becomes accordion, you can see the lumen has gone down significantly here. So in this situation, you can't take you use a stiffer wire. You have to go for a softer wire, which has got a less body because IVUS doesn't need any body. You just need a wire to get into it. This is another important thing. Spasm. What is the role of spasm? Before getting IVUS, the patient should have been ideally anticoagulated, just like a PCI. And this is the lumen area before giving NTG. You see here is 3.6. After giving NTG, you can see the lumen area is 5.4. So a provision of a nitroglycerin is a mandatory step without which IVUS should not be done. Artifact air, a proper flush is very essential. Our staff should be taught very well about this artifacts that can happen. The older IVUS system can also create artifacts called as nerd, which are not seen these days. If a nerd is going to be seen, then we used to go for a step down, or limb down. It removes the particular artifact. If this picture is going to be seen like a series of hypoechoic concentric structures, then nothing should be done. It has to be pulled out and flushed properly because it's a source of air embolism. So let's go with stent selection strategy. How? So the most important step in identifying a stent size by IVUS is identifying a reference segment. So how do you identify a reference segment? Reference segment this slide is provided by Professor Sang Woo Kim, who's my mentor in South Korea. So how do you identify a reference segment? Reference segment should be a near normal looking segment located within 10 millimeter from proximal landing lesion and within 10 millimeter from the distal lesion. So if this is the lesion here, the angiographically this lesion looks good, but there is a lesion here. If the plaque burden is going to be less than 50% here, more than 50% here, I will not land the stent here. I will land the stent here. So that is the way we may end up putting a stent here alone if that we are going to do angiography. But look at the IVUS here. This is the good zone at the proximal. This is for proximal reference. This is the immediately before the disease zone. This is at the distal zone. This is the very tight. Only the catheter alone is seen. If you want to measure a mid-wall to mid-wall, what is mid-wall to mid-wall? The bright thing is the external elastic lamina. So this is the plaque. So I go from here. Sorry. So can you guys see my arrow pointer? Hello?
Sir, we are not able to see the pointer.
Okay,
Yeah, no,
this arrow.
now we can see. Yeah.
Oh, okay. So mid-wall to mid-wall strategy is utilized when you don't see have a good proximal reference or good distal reference. In that particular situation, you go to the area where it is the where the vessel is significantly diseased, and in that particular segment, you go from mid-wall to mid-wall. This is the extra elastic lamina. There is no block is extra eccentrically deposited here. So from this point, I will go all the way to the mid-wall. This point. So this is the stent size where I will utilize if there is no good proximal reference or good distal reference. So I identify this as a proximal reference. This is a 10 millimeter within 10 millimeter of the disease zone. This is the tightest zone. I'm going here. Here again the plaque is there, though we have not mentioned about the plaque burden here. But once you look at this point here, there's a good amount of plaque is here. Yeah, of course, it's definitely, obviously, it's going to be more than 50% in this zone. If at all we are going to land the stent here, we will miss this zone. And if any disease zone is going to exist within 5 millimeter of the distal edge or proximal edge of the stent, they have been clearly shown to have increased MACE events that can be because of dissection or edge restenosis. So this is the distal difference. You can clearly see the difference between this point and this point. So of course you are increasing the stent which is going to be 10 to 15 millimeter more. That is the inherent advantage or inherent. If you go with the concept that more longer the stent, more restenosis. That is very true. But provided that the benefit of doing IVOS is you are optimally covering the lesion, the risk of putting a longer stent is mitigated by covering those abnormal segments with a DES. If you are going for a BMS, then nothing wrong in landing it here. But if you are going for DES, which is the norm here, there is no BMS existence of BMS at this point of time in the world. So we have to go from here all the way to here. So how to define reference segment? I'm telling it again for the benefit of postgraduates, especially exam going people who are going to interview in coronaries 6 months or 4 months from now independently. So you have to identify the segment 10 millimeter proximal and 10 millimeter distal to the approximate angiographic landing zone. From that segment, it not necessarily 10 millimeter, it can be at 6 millimeter itself. Then you stop it there. Only point there should be the plaque burden should be less than 40% to 50%. Some studies have used 40%, some studies have used 50%. Anything less than 50% is good enough. uh, it should be within 10 millimeter. That's it. That should not be any major intervening side branches. If there's going to be a big branch that is going to come here, you will go either above the branch or below the branch. Ensure that you are not stopping at the level of the branch, because it will create significant difficulty in recrossing the branches. So these are all the points I would say, why I would emphasize while selecting a stent based on imaging. We should image stent from most normal. So it's not normal segment. It's called as most normal segment to most normal segment. The proximal reference and distal reference diameter, the segments should have less than 50% plaque burden without any dissection, without any thrombus, without any calcification. And there should not be any prominent side branch coming at the level of proximal or distal reference that can actually oversize or undersize that can have a significant impact on the sizing of the stents also. So also note that when you are dealing with a bifurcation lesion, you should know the expansibility of a particular stent. When another advantage of doing imaging is, okay, distal reference is 2.5 and the proximal reference is 4.5, and there is no stent that is going to go from 2.5 to 4.5. So I have to, what is the stent length there? Should I go two stent? If it is two stent, what is the first stent? Is 2.5 into 28 or 2.5 into 18? What is the mid-wall to mid-wall length in the particular proximal segment? Can I take a 4 stent there? These are all the questions that you have to keep it in your mind when you are dealing with the question stent selection sizing based on imaging. So no, you should know the expansibility of individual stent. You should know the cell opening of individual stent. You should know the recrossability, how difficult and how easy is it to recross a particular stent. For example, the Cypher stent, which was the original DES, has a closed cell design. It's very difficult to recross it as compared to the currently available third or third generation DES, which are all the DES currently available have got open cell design. When we say open cell design, it doesn't mean that it means that the I will show some of the pictures of the stents. They are good enough to rewire it. There is no connectors between them at the particular segments. And side branch ostial expansion is also very important in determining. For example, if you're going to put a stent that You are rewiring it, you are doing kissing and all, but by doing kissing, it expands only to 2.5 in a distal left main. That's not a good stent for distal left main. These are all the points that you should remember when you are going to deal with the left main bifurcation. Also, you should also look for least in preparation. Can I do this intervention without in any block modification strategy? Or if the block modification strategy is required, what kind of block modification strategy should I use? Should I use rotablation? Should I use IVAS? What kind of strategy should I use? These are all the questions that are essential to be considered when you are doing IVAS or OCT. So let's go to this slide. This slide may not be kind of a slide intended to be shown here, but this slide I am showing it here so that our people can understand what exactly we are dealing with. So this has to be an 1 second. Now it should be fine. Yeah. Okay, this is the table which I got it from got it from journal published from European group. They have studied the most of the third generation DES. If you look at here, there are only two stents that have got three kinds of more than two platform. One is Synergy, other one is Onyx. Synergy has got three platforms: 2.25 to 3, 3 to 4, and more than 4. Well, Onyx is a wonderful stent which has got four platforms. It's 2.25 to 2.75, 2.75 to 3.5, 3.5 to 4.5, and more than 4.5. There are only two stents that have got a platform size more than 4.5. One is Onyx, the other one is Taxis Liberty, which is not available anymore. So all the other currently available stents, including Zions Alpine, which is not available, which is available in US, Zions Expedition, whatever, Ultimaster, Biomatrix, only two stent sizes. That means the stent is the same stent, only the balloon is different. But here in Synergy and Onyx, the stent, there are three types of stent, there are four types of stents respectively here. When we look at the stent, we should know what exactly, how does it look. What I'm showing is a Zion stent. The Resolute Onyx stent completely, the shape is completely different. The technology, how they made is it's woven, it's made by a woven wire. So it doesn't look like this. But this is the way how majority of the non-Onyx stent looks. These are the spikes. This we call it as crones. This is called it as connectors. The peaks are crones and connectors. Normally, there is a direct correlation between metal to artery ratio. Higher the metal to artery ratio, more restenosis. This has been shown from Cypher study. That is the reason why the stents which were 140, 150 microns in Cypher has been dropped down all the way to 71 microns in Synergy. So you should also remember that stent thickness, because more the stent is going to be thicker, higher chance to have stent thrombosis, higher chance to have restenosis. But having said that, if the stent is going to be very, very thin, then you lost the advantage of over expanding the stent. So this is the normal size of the stent. This is the crown, this is the connector. Normally three connectors. If you see here, as the stent becomes bigger and bigger, there is only 2 to 4 connectors here. 2 to 4 connectors here. There are 5 connectors. There are 3 connectors here. There are the 3 connectors here. The crowns are going to be 6 here, and crowns are going to be 9 here. So more the crowns, more the metals. Can expand very well. That is the reason in larger stent there are 9 crowns. In smaller stent there are only 6 crowns. Of course, there is going to be more curvature. It can expand very well. So look at here. This is normally expanded stent. This is abnormally expanded stent, not abnormally expanded, over expanded stent. So this point needs to be emphasized. So this is called a cell opening. This is the normal cell opening. This is an abnormal cell opening. In this particular study, they have dilated the stent 3O stent to 4O stent with a 5O balloon, 4O balloon, 5O balloon, and this large stent with 6O balloon. Once the stents gets expanded, what all the things that happens, they lose their flexibility. So if the stents are going to have these crowns properly, that means they can flex with the cardiac systolic motion and systolic and diastolic motion of the particular heart. If they are going to be, if they lose their crowns, they become straight, then they become more stiff. So there's a chance to have stent fractures. So this is the chart that the same people have published. These are all the underlined highlighted point that I would suggest all the exam going PGs to remember. So the stents in Synergy have been classified into small stent, moderate, and large vessel stent. So yes, they dilated the 2.75 frame with a 5O balloon. In spite of dilating with 5O balloon, it goes only to 3.6. Keep it in mind, it's not safe to dilate a 2.75 vessel with a 5O balloon. Vessel will rupture. So it's only in it's only bench side test. You should not take it what they are doing it to your clinical bedside procedures. So even with a 5O balloon, even in outside the body, it's not going to go more than 3.6. If, let's proceed. I would say it will go only to 3.3 inside the vessel, because there's a large amount of resistance that's going to the vessel is going to receive from pericardium too. So it's going to be, it will not, definitely it cannot be 3.6. It will be less than that, but it cannot be more than that unless it's going to perforate. So these are all the numbers that I would suggest you to remember. So if you look here, the greatest number achieved is Ultimaster, which is the 4 ocean that go up to 5.8. But if you have a left main, which is 5.9 in diameter, you can't take any other stent except for Resolute Onyx 5O stent, which goes to 5 point. That's the only extra large stent available in the market at present. So these are all the things that you should remember while dealing with, especially with left mains. So over expansion, most of the people have discussed about under expansion. Under expansion goes with stent thrombosis. Under expansion goes with instant stenosis. Under expansion goes with more MACE even. But many of these companies, they don't discuss about what is the problem that can happen with over expansion. So what are all the presumed problems that can happen with over expansion? I already told. The stent which are flexible, they will become very tensile. So stent fracture can happen. The cell opening, which is shown here, will become bigger. More the cell open is going to be there. This part, for let's proceed. This is the point A. This is point B. The midpoint is point C. The amount of the distance that the C has gone from A and B respectively is going to be few microns higher as compared to this point, this circle. So the drug delivery to this midpoint of the circle is going to be lower. So no one has studied what exactly is going to happen in this particular situation. Some part of the stent some part of the vessel that has received the DES is receiving good amount of drug, while the other parts are not receiving good amount of drug. So that particular vessel segment, which has vessel segment, it's not receiving any drug. So it's only being treated like a BMS in the particular zone. One small specule is good enough to stimulate instant restenosis, either by neointimal hyperplasia or by neoatherosclerosis. So no one has, people have not come up with good data. What is the effect of overexpansion on instant restenosis or stent thrombosis? And more overexpansion, even with the nominal expansion, the OCT studies some of the OCT studies have shown that the abdominal portion of the stents may lose the drug. Okay, so with overexpansion, it's presumed that some more amount of drugs can also be taken out. So overexpansion is good for a vessel. Appropriate, I would say, appropriately expanded stent is much better than under expansion, and it is far better than overexpansion. So these are all the points I would like to emphasize, that we don't know the over expanded vessels outcome on clinical MACE. So this is the thing we have already discussed. This is the proximal landing zone. This is the distal landing zone. The plaque burden is still there, but it's less than, let's presume it's going to be less than 40%. This is the distal landing zone. This is the disease zone. If this is not good, I will go with the disease zone. I will go from this point to midpoint of this point and take a stent and slowly deploy it and do a repeat IVS. Look at the minimal stent area that I have obtained according to the particular vessel segment and go accordingly. Okay, the largest reference lumen over there, proximal or distal, mid wall, and media to media. They often this is discounted by approximately, when we say media to media, in the proximal reference and the mid reference, actually we are going to go from the outer surface of the media to the outer surface of the media here. This is called this is the picture. If I'm going from here to here, this is called as lumen based stent sizing. If I'm going to go from here to here, it's called as mid wall to mid wall. The red one, mid wall to mid wall. If I'm going to go from here to here, blue to blue, it's called as medium kind of mid wall to mid wall in the plaque segment. This not this the blue one cannot be done in a proximal or distal reference segment. I hope I'm trying to you get what I'm trying to say. The yellow line and the red line are done in proximal and distal reference segment, while the blue line, which is mid wall to mid wall, is done in a segment of the vessel which has got maximal amount of disease with the minimal lumen area. So let's go with remodeling. What is remodeling? As I told earlier, the Glogov hypothesis, remodeling happens. Initially, it is positive remodeling. Later on, the vessel luminal encroachment happens, and some vessels go for negative remodeling. So this is the reference. Let's presume this is the reference. This is the disease segment. I calculate the EM here. I calculate the EM here. I summate the EM area. Let's presume the EM area is 10 here. The EM area is 8 here in the distal reference, and the EM and the disease zone is going to be so 10 plus 8 is 9. If it is going to be 11 in this zone, so 11 by 9 is definitely going to be more than 1.05. That means it's a positively remodeled vessel. What is the significance of positively remodeled vessel? Positively remodeled vessels have more chance to go for restenosis, have more chance to go for neoatherosclerosis. And this, if you don't treat this vessel, this can give future ACS. If provided the lumen area is going to be more than 400, it's a medial elevation, we don't send this lesion. But in future, this can give rise to ACS. That is positive remodeling. What is negative remodeling? Again, EM area here in reference, proximal, EM area here in distal reference. Summate this area 10 plus 8, 9. While here the EM area is going to be 8. So 8 by 10 is going to be 0.8. So it's a negatively remodeled vessel. So a negatively remodeled vessel, I have to be very careful because all these complications related to ballooning or stenting like perforations are common in this negatively remodeled vessels. And in diabetic patients, these negatively remodeled vessels are quite common. So you have to be very careful. That is the first step in determining second step in determining stents based on imaging. So how to determine reference segment in OCT is the same concept. Pullback, OCT pullback. You identify the reference segment, distal and proximal segment. Then you get the lesion length. If you are absolutely sure, you can take a 26 or you can take a 28. Go slightly distal here and slightly proximal here. Nothing wrong in doing the strategy. You'll be able to identify the intima, media, and adventitia very clearly in OCT. So you look at here. This is the distal reference. You can see all the three segments. If you see all the three segments like this, a normal vessel in more than 180 degrees, that means you can take it as a reference segment in OCT. For example, because the penetration of OCT is not good, we don't. There are good amount of fibrofatty plaque here. Sometimes the people say because the penetration is not good, we are not seeing clearly. So we cannot be very sure. So that is the reason why in OCT we take only if 180 arc of EM is seen, you can take this as a reference segment. Here 360 degree of EM is clearly seen, and there is a plaque, there is a fibrotic plaque, but the plaque burden, if you measure, it's going to be less than 40% here. So you can definitely take this as a proximal reference segment. The stent now, how big should I take the stent? That is stent sizing. In the whatever we have discussed before is based on IVUS. Whatever we are going to discuss now is based on OCT. So in OCT, you can clearly see the lumen. So you are seeing the tunica intima, and then you are perfectly see the lumen. In IVUS, you don't see the tunica intima. You are going to include tunica intima as the in the lumen based stent sizing. So IVUS can cause more problems like dissection, the edge dissections than OCT because, and of course, IVUS gives more lumen area. That's the advantage of it. And the problem with this, you are going to stretch the vessel a lot with IVUS. In OCT, you are going to perfectly size the lumen to lumen. This is lumen to lumen. This is mid wall to mid wall. And this is, if you see here, this is the media. So this is the external elastic lamina. This is possibly external elastic lamina, though there's going to be a plaque here. So this is the EM based strategy based on OCT. So if you see here, the diameter gradually increases from 3.0, 3.1, and 3.2. Yeah, 0.1 millimeter in diameter is good enough to increase the lumen area. Keep it in mind, the area is pi r square. So 0.1 into 0.1 into 3.14. The area is going to be significantly higher with even with 0.11 millimeter increase in diameter. So it is clear that more lumen area is good, but more plaque burden is definitely bad. So before identifying a reference segment, you should go for plaque burden at a particular area. So these studies, Falgun has recently described, so I'm not going into the detail of these studies. So in general, image-guided PCI is superior to angiography-based PCI, especially in proximally located vessels that includes left main, distal bifurcation, prox LAD, prox circ. So this study, I would like our postgraduates to remember throughout their life. This is the one study, all-comer study in which IVUS has been shown to be superior to angiographic-based studies. All-comer study, they included 10% of left main, 25% of bifurcation, 66% of this patient has got B2 or type C lesions. So how did they identify the reference segment? They went with 40% plaque burden in the reference segment. How did they define post-PC success criteria? The minimal lumen area of the particular stent should be more than 5 millimeter square for non-left main segment, non-left main vessels, and or it can be more than 90% of distal deference area. If it is going to have, if the plaque burden is going to be less than 50% in the landing zone, for less than 40% in the landing zone, the other than the, just imagine they identify the landing zone with less than 40%. In addition, they went 5 millimeter proximal and 5 millimeter distal to the landing zone. They found that within this 5 millimeter of proximal landing zone, within this 5 millimeter of distal landing zone, again the plaque burden should be less than 15%. So this is a new concept that they have proposed till that point 2008. Before the 2018, no one was looking at it. It is not only the site where the stent is going to land, it is the site 5 millimeter proximal and 5 millimeter distal. The vessel reacts within this segment, vessel wall. So they went up to this segment to I say that okay, we have to have a proximal and distal, proximal 5 millimeter and distal 5 millimeter to the stents less than 50% of plaque burden, and there should not be any flap which is more than 3 millimeter. They've got a different criteria how to deal with plaque. If the plaque burden is going to be more than 50%, what did they do? No, that is, I mean, it is very essential to know this when you're intervening. But in general, the lumen area should be more than 5 millimeter square with the distal more than 90% of distal deference area without any dissection, which is more than 3 millimeter, and the edge to edge plaque burden within 5 millimeter of both proximal and distal deference should be less than 50%. And they showed that significantly reduced MACE event. That is predominantly because of target vessel failure and clinically driven target vessel revascularization. There was no difference in death or cardiovascular mortality. Of course, there is no decrease in death or cardiovascular mortality in PCA itself. Having said that, IVUS guided PCA has been shown to reduce the mortality, even cardiovascular mortality, and even all-cause mortality in a meta-analysis published way back in 2017 itself. If you isolate the studies with left main alone, it decreases events. But if you goes with all-cause mortality, it does not decrease the even clinical hard endpoints, just because we are we have included all low-risk patients. So if the criteria, all these three criteria should be met, if all the three criteria have not been met, then they labeled them as suboptimal IVUS. 25% of individuals had suboptimal IVUS in this particular study, and they behaved similar to angio results. So that is the reason I initially told you, it's not only acquiring and analyzing the IVUS, we have to act accordingly. There is a specific guidelines how they have acted in this particular study. I would suggest all of us should follow the particular steps so that we can kind of get the same kind of result what those people have documented. So this is one statement from European Heart Journal, European ESC people. They have suggested two strategies to measure the lumen based on IVUS or OCT. One is lumen based, other one is EM based. The lumen based, if you see, I will go with the lumen to lumen. For example, here, for example, let's put whether it's IVUS or OCT doesn't matter. They didn't describe about a mid wall to mid wall. They describe only lumen to lumen or EM to EM. If I'm going from lumen to lumen, I can add 0.25. I can add 0 to 0.25 millimeter to the mean diameter. If I'm going with EM to EM, I will take the nearest to 0.25. Let's presume the lumen to lumen diameter, mean lumen to lumen diameter here is 3.3. I can definitely take a 3.5 millimeter stent and then utilize it. If the EM to EM diameter is going to be 3.76, then I will take a 3.75 stent which is available, which is not available here, or I will take a 3.5 stent. I will not take a 4O stent. That is the point I would like to emphasize here. If you are going with EM to EM, you undersize it by 0.25. If you are going to go with lumen to lumen, you can add 0.25 up to 0.25, or you can go without adding anything. 3.3, you can take a 3.25 stent. I mean, you can take a 3.5 stent, or you can take a 3.25 stent, deploy it and overexpand it. Having said that, overexpansion has got, we don't know the effect of overexpansion. That is the reason I am trying to say, previously I used to say you can take a smaller stent, overexpand. No, you have to appropriately size the distal reference segment, so you can optimally size the proximal, optimally dilate the proximal segment using pot technique. Okay, so these are the two strategies we have described: lumen based and EM based. For a tapering vessel with a normal distal reference, we can use average lumen diameter of the distal reference as stent size. For example, if a LAD is going to be tapered, basically it's a diffuse disease segment. But if you get a distal reference which is not diseased, you can use the mean diameter of the distal reference. When there are plaques in the entire vessel, diffuse diseased vessel, you cannot identify. Of course, you cannot identify proximal or distal reference. You cannot all the way go to left main and put the stent for a mid LAD when there's a diffusely diseased vessel. In that particular segment, to identify a zone where the disease vessel is near normal, even with 50% plaque burden, near normal. But in that segment, particular vessel, you don't go with proximal or distal reference. You go with the minimal lumen diameter, minimal lumen area vessel. Take mid wall to mid wall and deploy the stent at the subnominal pressure. Do an imaging again. If you are happy with that, if there are no distal dissection, the lumen area is good, then you come out. If it is not, then you say post dilate the vessel appropriately. The post dilatation up to 80 millimeter is essential in ultimate trial. So this is the picture which we should all. I wish one of our PGs can take a color printout and paste it in our lab. If you do an imaging, these are all the parameters we look at. So that there should not be any distal dissection. The significant distal dissection. A significant distal dissection is defined by a dissection that extends into media towards the adventitia by OCT or IVUS. A dissection that it has a 60-degree arc. Number one, a dissection which is 2 millimeter in long. These are all significant dissections by OCT. In any dissection that is seen with IVUS is significant dissection. Number one. Number two, plaque protrusion. If there is going to be significant overexpansion, the plaque gets squeezed and some of them will protrude. So overexpansion may lead to plaque protrusion. So we get doubtful whether it's a plaque or thrombus. We don't know what to do. Plaque protrusion has been shown to associated with stent thrombosis and institutionosis, especially if they're going to encroach the lumen and leading to a lumen area less than 5 millimeter square. Another thing is malopposition. We don't know the effect of malopposition, but there is an indirect association with the early and late stent thrombosis with malopposition. So in general, a malopposition of more than 4 millimeter, 0.4 millimeter distance, and a length more than 1 millimeter, more than 1 millimeter, that needs to be tackled well. Any malopposition seen with IVUS needs to be treated. So this is the from proximal to distal or distal to proximal. Malopposition is going to, of course, going to happen more commonly in the proximal zone. So malopposition of more than 400 microns and more than 1 millimeter needs to be treated. Plaque protrusion more than that encroaches the lumen leading to lumen area less than 5.5 or 5 needs to be treated. Dissection which extends into media or more than 60-degree arc or more than 2 millimeter that needs to be treated. So Preetham, do we have time or?
We have, sir, 9 minutes more. We can schedule a second part where we can have a detailed discussion also, sir. No issues. You can continue, sir, till 10 o'clock.
So let's go with this first case. So this patient is an IVUS guided PCA. It is not IVUS optimized. So every decision in this particular patient was based on IVUS. A 67-year-old male, anterior MI, lysed, moderate LV dysfunction. I thought it's a 101 lesion initially. Patient angiography was done in Madurai. Cabbage was done in Madurai. Unfortunately, SVG2 lima was placed. Patient had a graft closure. When he was diagnosed with graft closure, when he had a non-sterilization MI letter with the pulmonary edema, taken up for image guided PCA. So this is the angiography of the particular patient. Went up with the groin, 7 French guide. You can see the hazy looking distal left main nostril circumflex lesion in the cranial view, and the tight left main lesion can be appreciated here. So if it is going to be a complex lesion, I usually go with a long sheath. Always go with a long sheath. At least if not 45 centimeter, at least go up to aorta. That increases the support that you can have if you want to do kind of rotablation. So this is the image I was running this particular patient. We are pulling from circumflex to left main initially. This is the freezed frame. This is the way how we have to measure the plaque burden. We are measuring the yellow circle is the EEM, the red circle is the lumen. You can see the plaque burden here is something around 64%. Any plaque burden in the ostium more than 50% to 70% is shown to have significant. The side branch is prone to. We are prone to lose the side branch. But here the side branch minimal lumen area itself is going to be 3.6. So we upfront we decided, okay, we are going to handle this patient with using two-stent strategy. Even in this particular cranial view, you can appreciate a significant ostial circumflex lesion as compared to LAD. So this is the pull from left main to LAD to left main. The LAD ostium looks okay. So we identify the distal reference segment. Again, you can see the plaque burden is 21%. The LAD is reasonably disease free. The yellow line is the EEM. Red line is the lumen. There's no significant plaque here. So we proceeded. This is the ostial LAD segment. The plaque burden in ostial LAD is 52%. This says that I cannot leave the stent from left main to circumflex. If the plaque burden in the ostial LAD is going to be only 20 to 30%, one school of thought in dealing with 101 lesion says that you can stent from circumflex you can stent from left main into circumflex and decide about left main LAD strategy later. But here the ostial LAD has got a plaque burden of 52%. Actually, it's going to be more than 52%. It's underestimated here. More than 50%. We have to. It's not a 101 lesion. It's 111 lesion. Okay, this is the picture that we are seeing here. So this is the distal reference segment. This is the ostial LAD segment. This is the distal left main segment. This is the ostial circumflex segment. So this we are primarily, as I told earlier, we are primarily dealing with the 111 Medina lesion with the more significant lesion in the left main and the circumflex rather than the LAD. So this is we initially dilated the lesion. There is no significant block. The other thing what I should have told there is I wish I should have told, but I forgot to tell. There's no significant calcium that was appreciated in the particular segment. It's all because it's all fibrofatty lesions. After adequate pre-dilatation, we deployed a 418 everolumus eluting stent here. Recrossed it. Then after recrossing the particular so this is this one this is a modified Zabos technique. The wire is in the aorta. The same wire is used to we are trying to get the same wire into the LAD. I didn't try to get the wire into the circumflex first. With the loop I entered into LAD, ensured that I have gone through a loop and then pulled back the same wire and used to rewire it to the circumflex. These are all the trivial techniques that can help us in avoiding major problems later. So later on, we opened the strut with the 2.0 into 12, 2.5 into 12 balloon, and the tap technique was used. In the tap technique, we should ensure that the 50% of the balloon that is across the side branch is distal and 50% is proximal to the vessel. And in addition to for example, here you see here it looks it's too much inside the left main, but here you can clearly see it's appropriately placed at the ostium. And we pulled slightly 0.51 millimeter into the vessel and then deployed it. This is the post-deployment shot. Looks good. But we don't want to leave it like this. We want to post-dilate the one. This step I have never done this except for this case. Usually after deploying the stent in the side branch, both the balloons have been pulled and we kissed it and we came out. But we saw some amount of haziness in the mid segment, so we thought of post-dilating it. This is a risky step because the post-dilatation here can cause damage to either the LAD stent or circumflex stent. So we intentionally didn't go too much inside the too much towards the neocarina. We kept it here itself and dilated it. So this is the end result of the particular procedure. There was some outpoaching like structure here seen. It's most likely a block prolapse. This is sorry, this is not playing. Okay, so this is the important thing. This is the end result of the IVS. So we are pulling from left main, LAD to left main. These are all the minimal lumen area, minimum stent area what we have got. Inside the left main is 12 and inside the LAD is 9.7, inside the circuit is 8.9. So a reasonable amount of lumen area we have acquired. I wish I can stop this. Yeah, that is the Kareli. That is the Kareli. You see the lumen there. That is the segment where that should be seen in tap. That should be seen. This part should be seen in tap. If it is not seen, that means we have missed the ostium. Yeah, this portion should be seen in tap. This is the LA. This is the left. This complete thing is left main with the small stud with 1 or 2 studs inside the left main. This should be seen in any kind of tap technique. It should be seen. So this is how we started. This is how we ended. I wish this patient did very well for 2 years. Later on, I learned from his, he continued smoking after 1.5 2 years. He stopped his he's no more now. We lost him. He stopped his antiplatelets without my knowledge. 1 month later, after his demise, I mean 2 weeks later after his demise, I was called by his wife saying that he started smoking and he stopped his all antiplatelets. Unfortunately, he's no more now. Before doing left main PCA and a surgical opinion was again consulted for Lima to LAD. He was declined for Lima to LAD as he was having frank pulmonary edema at that point of time. Even now I wish he could have been taken up for Lima to LAD so that this guy would have been alive. So this is the message what I would like to emphasize here. It's not only doing the procedure. Maybe I should have persisted hard with the surgeon. Please take. I mean, unfortunately, he didn't take and he didn't make it. He stopped antiplatelets and he's no more now. Okay, things apart, let me finish with this particular algorithm which I made. That's the approach to size the stent based on IVOS or OCT. First thing is assess the remodeling of the vessel, proximal or negative, positive or negative remodeling. Identify the distal reference segment. If you are able to identify, you can go with these two strategies, lumen to lumen or EM to EM. If you're not able to identify a reference segment, even proximal or distal reference or remodeling, you are going to do mid-wall to mid-wall stenting with moderate pressure inflation followed by sequential post-dilatation based on imaging. If it's a negative remodeling, there is no way, and you are able to identify the reference segment, you cannot use EM to EM based strategy because it may cause more problems like perforation. You should go with only lumen to lumen based media based. If the vessel is going to have a significant kind of a diffusely diseased vessel, then with a significant mismatch between proximal segment and distal segment, you cannot take a single stent. Of course, 2.5 cannot go more than 3.5 in most of the, sometimes it can go up to 4. It can definitely cannot go more than 4. It's going to, if you are going to go more than 4, if you presume you have taken a 4.5 balloon and you are inflating to 4.5, it is not going, if you're going inflating to even to 18 20, it's not going to go more than 4. You're going to have fractures only. So there's no use of you using the strategy. Rather than use two stents, one smaller stent and overlap it with another bigger longer stent or smaller stent based on the vessel anatomy. So with this, I would like to conclude my talk. Uh, I have an MCQ slide. I don't know where it is. Yeah, here it is. So postgraduates, exam going PGs. I've directed the question is directed to the exam going PGs. This is a patient who has got this is the left main. This is left main. This is aorta ostium. This is left main. This is we will see. This is the distal left main. I'm not going to tell you anything significant. What is the strategy you will follow here? You can have a look at the number here. I will go very. Please give me 2 minutes. This is an important slide. You can get. It's a number game. Okay, you are looking at the distal left main. You identify the numbers. What you want to do. This distal left main was kind of borderline in the angiography. So and there was some calcium there. I'm not going to tell anything more than this. This is you have got the numbers and you have got information where the particular image is obtained. EGPGs, Vikas, Aditya, Bala, and Bavitra. Are you guys there or not? Am I audible? Satame ganame?
Yes, sir.
Okay. Audible dana. Okay. I'm going back. I'm going the picture again. Give me 2 more minutes, please. It's very important. Distal
Bhupati,
left
first
main.
tell the question, then show it again. What is the question you want them to answer?
Okay. Question is okay. Let me go to question. Do you need any extra data? First thing, or the postgraduates, do you need any extra data before? And this is the question. Question is, I will tell you. The question is incorporate along with the answer. What is the strategy you are going to use?
Sir,
Do you need
LC I was run, sir. LCX I was run.
LCS IVAS was done? It's a good question, but it was not shown here. The plaque burden in the ostial circumflex is 40%. You want any information?
Yes, sir. Based on L6 only, we can devise whether we want to go for a provisional
I told you it's 40% and the lumen area is something around 4.5.
Question is simple. Are we going to use a cutting balloon type of balloon with the single stent or two stent, or rotablation with single stent, two stent? That's the question. Am I right, Boopathy?
Yes, sir. Yes, sir. I didn't put that way. I want to. I want them to think. Think under this one, sir.
No. Why I'm saying this, clarifying is now show the image. They have to keep this question in their mind and see the image.
Okay. This is the
One stent,
strategy.
two stent, rota cutting.
That's true. So I should have done that way. So this is the question. This is the choices. The question is incorporated. The thing is, this is the patient. I didn't show the angiography intentionally so that you don't have any extra information. I told you the patient has got a borderline left main lesion. Number one. And I told you it's a pull from LAD to left main. And I told you a pull from circumflex to left main was done, which showed a block burden of 40% in the osteal circumflex, a minimal lumen area of 4.3 in the osteal circumflex. So this is the distal left main area. This is the cranial area. You have got some information about some vessel here. This is the minimal lumen segment area in the mid LAD. And this is possibly the distal deferens area. Now, question is, so will you intervene left main or not? Number one. These are all the questions what you should think in your mind while interpreting the angiography in IVUS. Should I intervene left main or not? If I am going to intervene left main, am I going to use single stent strategy or two stent strategy, as sir rightly told? Number three, should I use any specific device related block modification? Should I use an angiosculpt or cutting balloon or Wolverine balloon or rotablation? If I'm going to select a stent from here to here, am I going to use one stent from the LAD to left main all the way? Is it feasible or if not feasible? If it is going to be a rotablation, am I going to use one burr or two burr? I know it's a complex thing, but let's work this way. This slide, this case tells answers to all the questions. Are you guys following me?
Yes, sir.
Yes, sir.
Sir, what we can see is a lot of calcification is there.
Where do you see calcium?
The left main also we could
left
see.
main also is calcium.
Yeah,
Yes,
excellent. So there is a calcium which is going to the arc of calcium is almost 180 degree on the inferior side, and here something around another 60 degree and another 60 degree here. So entire arc of calcium is going to be with 180 almost 300 degree of calcium. So this
And
patient.
block burden.
So this question is, when the calcium is going to be more than 180 degree segment, what is the best block modification strategy? Is it angiosculpt, cutting balloon, or rotablation? What do you do?
rotablation is better, sir. But in this case, left main is risky with the rotablation. That is one thing I have. So left main calcification, rotablation means we have to be a little bit careful. That's what I wanted to say.
So I understand every rotablation should be careful, but here it is very essential to do rotablation because the calcium mark is more than 180 degree. Without that, the stent is not going to expand in this patient. Okay, and the plaque burden is 70%. And the first point is, I will intervene this patient.
Move the one small clarification.
One second, sir. 1 second. So, what is the answers you guys select? Yeah, Aditya,
Sir,
what is your choice?
The rotablation will be there. Plus LAD long lesion is there. So
Tell me the choice alone, please. Don't confuse me.
So first we have to modify the plaque with rotablation.
Tell me the choice for choice 1, choice 2.
4, sir.
So who is telling 4?
Because, sir.
Okay, Aditya, you?
So one second.
Sir, me also 4, sir.
Long.
I want justification. Don't go. It's a tough question.
Sir, post rota followed by one more IVUS run, sir.
Dr. Boopathy, what about the tight lesion, 2 millimeter lesion in the LAD? What about the calcification there? Can you show that segment again?
Okay, sir. For what do you do? Anything, what do you do?
Here, calcium arc is not more than it may be 180 degree, no? Not severe calcification here.
It's 180 degree. Yeah, it's 180 degree.
Yeah.
I didn't show the picture here. When you always look at the M mode, you see the calcium here.
Yeah, yes.
I should have shown the picture there. Unfortunately, I didn't show it. You take it from me, calcium is more than 180 degree.
Yeah, then I will also go for 4. But along with 4,
No. Vadivel, this is not for you. Why did you reveal?
Vadivel, your interruption is shocking.
High bonus marker ஏதோ ஒன்னு இருக்குது.
Yeah.
The first four choices, it's for PGs. The fifth choice is open to all.
The fifth choice, I will also want to do FFR for L6 also, block burden and vessels.
Okay, that's a good choice. I understand. With all due respect, the block burden is less than 40%, and the lumen area is going to be more than 4.3. I told so absolutely, and you can see here in the carina, you can see, though it's not an ideal view, it's well open. It's not going to close. You see here, this is circumflex.
Actually, distal left mainல வந்து அந்த calcium is in depth actually. Even if you do rotablation, will you be able to touch the?
No,
excellent.
You can't touch that, but it's mainly for LED we are modifying it. No.
Sir, whether you are allowed 2 bar or 1 bar, sir?
Excellent, Vinod. You got me. Excellent.
No, even if you are going to take 2 mm bar is not available in India. No, the distal left main size is 2.3.
It's available.
No. 2 bar. One small size bar, one large size bar.
So first question is, this patient require left main PCI. Let me talk to the postgraduates, then we will come to the last point later. This patient require left main PCI. Why? We Indian has got coronaries which are more towards Caucasians. Okay. So 5.74 is the lumen area. Block burden is more than 70%. There is no landing zone for me. I have to get the stent all the way to the iotarsal junction. Okay. So this patient require left main. First point. Second point, I didn't show circumflex to left main pull, but I told the values, it's 4.3 and 40%. So no need to go up front. Rescue bailout is different. No need to go up front with 2-stent strategy here. So I'm going to handle left main as a lesion, and I'm not going to do 2-stent strategy. I'm going to go with single stent strategy, provisional stent strategy. Number 3, I also noticed almost 300 degree of calcium here, which are 3 parts of calcium, 60 degree, 60 degree, and 180 degree. 3 parts of calcium. So I need a rotablation here. So what is the diameter of the stent that I will use here? 4.9, 2.3 and 3O is the vessel here. 2.3 and 3O is the luminal diameter here. But what the blue one, we are definitely overestimating. Don't go with the blue one if there's going to be calcium. So go with the luminal area if you are having calcium. Okay. So it's the 3O left main. Definitely it's a tight left main for the particular patient. 3O left main is not going to be 3O here. The lumen area is 5.7. Block burden is 70%. This is the Austrian LED, 60% block burden. Luminal area is diameter is 1.8, 2.7, and area is 3.86. So it's a very tight, of course, a very tight LED, significant amount of block burden. And here, the area is 2.11. The calcium here actually is more than 180 degrees, something around 240 degree in this portion particularly. And I'm going all the way here. This is the distal reference segment. Diameter here is 2.1 to 1.8. So point number 1, I wish my postgraduates would have asked me what is the stent length, what is the distance between proximal reference to the distal reference. That is the reason why I put the question, do you need any more data? So stent sizing also includes length. So length is based on the distance between proximal reference to distal reference. The distance between this vessel to this vessel is 50 millimeter. So no stent is going to cover, number 1. Number 2, this is located in mid LED. Mid LED and the reference segment is 2.18. Even if I'm going to, it's lumen to lumen. Okay. So even if I'm going to add 0.25, it becomes 2.5, 2.4. So 2.5 I can add with the risk of little distal edge dissection in the distal segment. So if I'm going to take a 2.5 stent here, the maximum amount of expansion for the 2.5 stent is 3.5 without losing its integrity. I mean, without losing its architecture. So it is definitely not going to go to 4 or 4.5 in the left main. Okay. So, and the vessel is 2.5 here. So my rotablation here will be 1.25. And the vessel is definitely 3O here. And the, I mean, even in the minimum lumen diameter. So I need a rotablation which is at least 1.75 here. So what I'm trying to say here is the length is going to be for 50 millimeters. So no one stent is available which is 50 millimeter as percent. One stent is available, but that has been taken out of market. So one longer stent available at present 48 millimeter. Even if it is going to be 38 millimeter lesion length, there's no stent that can go from 2.5 to 4 without losing its architecture. So 100% I'm going to take two stent strategy here. I mean two long stent overlapping stent strategy. So to conclude, and along with rotablation with two burrs, 1.25 burr here and 1.75 burr here. 1.75 burr, I will not go all the way here. I will just ablate the distal left main to LAD. So two burr. So the choice, the option here, what we did in this particular patient was, we did left main to LAD provisional stenting strategy, assisted by rotablation with two burrs, 1.25 here, 1.75 here, and we placed two stents, 2.5 into 38 here, and another 3 point. We took a 3.5 stent, 3.5 into 23 here, and overlapped it, and post dilated the particular segments well. This patient is doing well even now with on ticagrelor 60 milligram once a day. I mean twice a day, along with aspirin 81 milligram. This patient has been readmitted. We did a check angio after almost 15 months later. She's all stents are patent. I hope you learned from this particular case. So whether to stent left main or not, number one, if I'm going to stent left main, I'm going to use single stent or dual stent strategy. For this patient, am I going to use any block modification strategy? Yes, block modification strategy. There's a difference in the size between distal and proximal. So I'm going to use two burrs. Number four is one stent cannot cover with so much of negatively remodeled vessel. So I have to use two stents. So that is the reason we have to put two stents from mid LAD to prox LAD, proximate junction, and another stent from proximate junction to left main. And we did pot kind of stuff. We got post intervention I was also, which because of time I'm not showing it. Thank you guys.
Boopathy.
Sir.
Did you use two burrs?
Yes, sir.
Okay. Today, the same patient, if he comes, will you use two burrs or something else?
Lithotripsy, I have answered in the chat box.
Oh, that's what I was asking. I was telling very well also. Shocking interruption.
Yes, sir. Intravascular lithotripsy is an option, but
yeah.
I personally I do not have an experience in intravascular lithotripsy, sir.
None of us.
Probably. Sir, continue, sir.
Yeah, see, because the Sada, what he said, same thing. Because it's a deeper calcium, no? You saw that in the left vein, distal left vein, the calcium is deeper. How does it work there? Will a rota reach there? We do a block modification. Whereas the shock will do better not today. By theory, it should do better now.
The calcium is not that deep. So if you see here, where is it? Yeah. You see the calcium here. It's very close to lumen. It's very close.
Here. Come to 12 to 3.
12 to 3 it will not reach, sir. But we don't need the stent will expand this way. Expand eccentrically.
For I'm very ignorant on this. See, if you have done the vessel, the lumen, no, the actual thing, not the plot. Outer wall, the lower from say 4 o'clock to 7 o'clock. How did it come to that curve? How do you draw this line?
So this is only approximation, sir. We don't know. For example, how it is done is it is not this EEM that is taken. We go proximally, go to the near normal left main segment, and we look at the diameter of the EEM there, and we put an approximate EEM with the same diameters here.
See, but as you rightly point out, this approximation occurs very often in IVAS than OCT.
Yeah, yes, 100%. That is the advantage of OCTs.
Yeah, that's the advantage and disadvantage also. You may overestimate or underestimate also, because there's the imaging gets added to a bit of imagining now.
Yes, sir.
Because there's a practical problem we have had, particularly when you don't do it properly, when you have reusing the IVAS catheter, when the image is bad. Often I see even experienced operator, even in live cases, they just draw one line. Say that everyone should, the audience should believe that is the outer line. They may be right also out of experience, but the audience left with think of imagining element.
Yes, sir. This blue line has been, it's only an approximative line because the same diameter, the EEM was same in this particular proximal left main, use the same we put the same EEM diameter there. It is absolutely not right, but that is the possibly the best way how we can measure. Otherwise, we can't measure at all. There is no branch that is going to happen between left main from here to distal left main. So we use that EEM where left main originates and use the same diameter, same circle like that, and take the EEM, sir. It's only approximation, sir. We cannot do it otherwise.
Yeah, that is the problem. We want to get more and more refinement. Maybe as the technology evolves, or the thermo IOS system, they all add to the clarity. Over time, we are going to get more and more.
Yes, sir.
We will move to the other talk straight away. I think they are probing. Are they ready, Preeta?